Hello, everybody. I'm a practicing therapist and a doctoral student of psychology. Today, we're going to go over something more clinical. We're going to go over what is schizophrenia and what are some of the characteristics. I'm not going to go too detail, but I want to give you guys a brief overview of what schizophrenia is and what it's not. Okay, so schizophrenia is not just hallucinations. There are many types of psychological impairments, diagnostic impressions that do have hallucinations. For example, if it's drug-induced, this is not schizophrenia. When we are looking for schizophrenia or schizoaffective disorder or whatever psychological diagnostic impression that we're looking for, we want to rule out any drug-induced behaviors because that is a different diagnostic impression. It can still be diagnosed, but it's different, and that is not schizophrenia. However, schizophrenia can be the onset of it can be induced by a drug. However, the difference is, are you still having some of these behaviors without the use of a drug? That's the main difference. It can still be set up onset by it. Sometimes that happens, unfortunately, even with bipolar. That's actually really common with bipolar too. But the difference is how it's characterized in the longevity of it, regardless of the actual substance, okay? When I use the word drug, I'm not using it I'm just using it for a clinical reason. We're talking about substance use. This is for clinical and educational purposes only, okay? So let's talk about what we're talking about here. Schizophrenia is a severe mental disorder, okay? It is characterized primarily by psychosis. However, what we describe as psychosis might be different from what people might perceive. Psychosis, from a clinical standpoint, is where the individual cannot distinguish, or they have trouble distinguishing, reality from their delusions or their hallucinations, okay? So typically the way we look at it is we look at it month basis. Are you having these symptoms at least per month? And we're looking for a couple of these. I'm not going to get into the details of that, but we're going to talk about what some of these criteria is, okay? The very first one is that delusion. We call it it's basically a clinical word for strongly held false beliefs, okay? So let's give an example. Maybe they believe their partner was cloned from, I don't know, they were cloned from somebody. So their partner is now a clone. Or maybe they feel like their partner is a cyborg. And they have this strong belief, and there's nothing that's shaking them out of this, right? I've had many patients where they had strong beliefs. I'm not going to get into the detail of what has been reported specifically, but they might believe that a statue or a painting in their house is actually a human. Or they believe that painting is God, or that they believe that this painting might, it comes out at night and cleans the house for them. And they believe that. They strongly believe it. No matter the fact that there is no evidence of this, maybe the house is still not clean, but they have this reality that is not their belief. But it is a false belief based on reality, but it's their perspective, okay? And so this is what we call a delusion, okay? The next one is hallucinations. So this is sensory experiences without external stimuli. Now, this is typically auditory or visual, and it usually is occurring while they're alert. And I'm going to give some examples that I've seen, but this is not always the case, okay? I'm just going to give examples, okay? This doesn't mean that I'm giving anyone's information away, but maybe you have an auditory sensation of some sort, or somebody is telling you, hey, this is what you have to do tonight, or I want you to do this, or they might hear their name. They might hear, go do X, Y, and Z, and it's actually they're hearing it. It's very real. Sometimes it's very loud. Sometimes it's a whisper. Sometimes it might be that they actually think it's like a distant, like they think their neighbor is making this noise. And then sometimes it gets closer and closer and closer. And sometimes that can be very suffocating. It's a very frightening experience sometimes. And they might not be able to differentiate it. Visual might be very obvious, like they actually see a cat in their house that's not there. It doesn't have to be distorted. It can be like something reality, right? And they actually see that. And they're struggling with this, right? And so that's something important to recognize. They might have very disorganized thinking, okay? They might have very fragmented thoughts, beliefs, and that it may be difficult for other individuals who do not have the characteristics. It may be hard to follow. And it's actually tangential. These conversations are usually off in a tangent. It goes in many different directions. It's very split up, branching off into many different things. And when you're not the individual, it's very hard to follow what the conversation is. And so an individual who does not have some of these symptoms or are not symptomatic of these, an individual who's not diagnosable with this, they may be able to communicate much more linear, or even if it's complex or abstract, it still has an overall conclusion. Individuals can follow it very well, right? An individual who may fall under this criteria, it can be very hard to follow, and it may even feel very fragmented, very difficult. And that individual may not even recognize it. They may not see it that way, okay? The next one is actually similar to disorganized thinking, but it's disorganized behavior. We might call it erratic actions. And some of these actions may actually impair daily functioning, if I'm being honest. And that may include extreme behaviors like talking to oneself. It could be laughing without any reason. It could be screaming at the wall. It could be having certain daily rituals that need to be done at a certain time. It may be sitting a certain position, because if you sit another position, you might be cursed. And so they have this perception, and their behaviors are based on those perceptions typically. Not all the time, but just erratic behaviors. Often I also see perhaps negative symptoms or disengaged symptoms where we actually see a reduction of emotional expression. We may see a lack of eye contact. A lot of them lack eye contact, which is fine. They may have struggle with initiating speech, and then once they initiate it, they may go on a tangent, right? Excuse me. Individuals also may seem very apathetic or detached from their surroundings. Excuse me. So these are some of the aspects, some of them, that we can kind of see, okay, this is schizophrenia, okay? And let's talk about the associated features. This is very important, okay? Often they may struggle with insight, okay? When we're documenting, like in our EHR, or it's called an electronic health record, anyone, simple practice, therapy notes, whatever it is, there's this section in our notes where we have to write down some of the cognitive behaviors, orientation, their physical appearance. This is just what we have to do medical wise, okay? And don't worry, no one sees these notes, so it's confidential, but it helps us to recognize these things. And the one I'm talking about is poor insight. They may struggle to recognize that their delusions are delusions. And even if they sometimes might realize it for a split second, they go back into it and say, no, this is real. I know that the painting wakes up at night. I know no one believes me. I know it sounds weird, but I feel it. I feel like that painting comes out and cleans the house for me. I know it, right? And so they struggle to recognize that delusion. It's very, that insight is very struggling, right? The next one is cognitive impairments, honestly. So this is not psychological, this is cognitive, or it is perceived out as cognitive, right? So they may have struggle with memories. They may struggle with planning and even processing information, actually, okay? The next one is the next section is we're going to compare this to different psychological disorders so that you understand. We did talk about substance-induced, but some people might be confused. How does this relate to bipolar with a subcategory of psychosis, right? And so the difference is with bipolar that has psychosis, the symptoms are aligned with their mood, whereas schizophrenia, it's not aligned with their mood. It's not aligned to how they feel at all. It can be, but it's not always. Bipolar, it's almost always aligned to their mood. And unfortunately, just truthfully honest, the functional history of bipolar with psychosis tends to function better typically than those with schizophrenia. This is just how we describe it in a clinical way. I'm not saying this in a way where I'm trying to insult anybody. I don't care. I do this for a living. I love this. I'm not judging anybody, okay? The next one is schizoaffective disorder, or some people might say schizoaffective. I say schizoaffective, but whatever you want to do. This one is just when an individual has symptoms of both a mood disorder and psychosis. So you could basically have schizophrenia and borderline, and that would fit under schizoaffective, right? Or just you have that psychosis in of itself, and then you have borderline's not a good example because that doesn't fit, but bipolar is a good one. Even though you could do it with a personality disorder, it depends on how your personality disorder is aligned and who's diagnosing you. That one's for another day. We're not going to get into that one, but that's kind of the basics of schizoaffective, okay? The next one is kind of the treatment of schizophrenia. Now, a lot of you guys know I'm getting my PhD in psychology. I'm not a psychiatrist, right? My aunt is a psychiatrist, but I'm not. And so we're not going to talk too much about medication, even though we're tested on that. We don't prescribe. So please understand that I will never be prescribing medication in my current path. Doctorate of psychology, they don't prescribe, okay? That's mainly clinical testing, okay? or research or therapy, whatever your branch is, whatever you want to do, okay? But the primary treatment that's really important is the individuals tend to be they want to be prescribed an antipsychotic, which is a type of medication. This will help reduce some of those negative symptoms, aim towards positive symptoms. Sometimes we want social skills training, and of course we want therapy, depending on what type of therapy that the individual has, right? If individuals are struggling with more compulsions, you might want to do more particular to like what is like, I want to say like more like skill-based, right? ERP or any sort of management. Then you can also do CBT or DBT for skills. I'm psychodynamic, and so sometimes you want to do more insight-oriented to help them recognize or detach from those delusions. But often individuals in this criteria, if they're doing outpatient at all, you want more frequency of therapy, and you want it to be combined with other professionals as well, because individuals need a lot of different skill sets, okay? It depends, okay? It depends on the severity. The next one is we want to talk about the onset and risk factors, and then we'll just wrap this up. Typically, this is going to be showing up for men. We're going to see more mid-20s, whereas so males, I can sometimes even see it teenagers. It can happen with females. So the range is late teens to early 30s is typically when you see these behaviors. Males, it shows up a little earlier, early to mid 20s, where females likely more in their late 20s to early 30s. And there is a genetic component actually. And we also see birth complications as a component, and some studies have shown that advanced paternal age, which is also a risk factor with autism, we see that possible link. However, there is no clear, complete cause. We don't see a clear factor. It has not been established yet in research. So I hope this video was helpful to somebody. Please like, subscribe. I'll see you in the next one.